So we're going to overview passive devices, overview active devices. I want people to really start getting comfortable with this language, passive and active devices for male stress incontinence. I think you're going to see more of this, and adjustable and non-adjustable devices. And then I'll go over my technique, how I do it, and go over really a few of the techniques and some lessons I learned. This table here is from an article that we just put together, sorry. And this was on active and passive devices, and it's in the IJUR journal, which is a journal of review articles. And so we did this together with some of the fellows and Rebecca, Rohan Bala, and we wanted to kind of get an idea of what's even out there, right, in terms of passive devices, right? There's quite a few passive devices to consider, and what are the advantages and disadvantages of certain devices. So the advanced sling, I think many people know that as a passive device, right? And worked well in non-radiated patients who had low volume leakage. The problem with the advanced, I think we saw some delayed failures. The Virtue, I haven't used Virtue, but I think similarly performing somewhere between 32 and 83% success. The Argus is a new sling that's coming that is adjustable intraoperatively, and I'll show you some pictures of that. The Adams, another sling that's going to be adjustable both pre and post-op, and I see that one maybe getting some traction in the sling world. Remix, I don't have experience with, another adjustable device, but very difficult adjustments. And then the ProACT is the only device you can really adjust easily in the clinic. I seem to be missing a slide here. I'm sorry. So the active devices that are out there, we have the artificial urinary sphincter, and then we have some new AUSs coming along the lines. And if you look at the AUSs, the trend is to make the AUS adjustable in a way that it can reduce the pressure and perhaps not have a pump. So I think this is exciting time and new technology that's coming along. Why are we even going there? What is the interest? And why can't we just stay with the AUS? It's the gold standard, right? Well, if you look at this recent study just published in 24, looking at long-term data, and this is great data going out 15 years. At 15 years, okay, 44% of your patients are going to have cognitive issues. So even if they don't have them when you implant them, years later they may have those issues and struggle to operate the device. Dexterity issues often go hand in hand with the cognitive issues, and they may not be able to pump the device. So if we can have a device that you don't have to pump, you don't have to think about, it can be a passive device. Now you're getting back to what would be closer to considered, your native continence mechanism, right? A lot of times when I put a non-active device in, meaning a passive device, they'll say, I'm not getting this. How is this going to work? I don't have to pump anything. It sounds too good to be true. And I said, well, did you have to pump anything when you had your prostate? Well, no. Okay, well, why would you have to pump anything now? Do you have to pump anything when you had your sling? No. Okay, so there are other examples of passive devices and natural continence. What about complications and even severe complications? I think you heard this over the lunch that if you do have a complication from an AUS, you're going to be going to the OR. Maybe you can take it out in an hour, but the OR might not be ready, and you're waiting 2 hours or maybe even the next day. And it really kind of wrecks your weekend, and your patients really struggle with this. They may have to be admitted, and I think the erosion that they suffer can be quite severe and lead to stricture and problems that may be not fixable in the future. So it's something to look for, and I think as the data matures, we'll learn more about this. This was the journal article that we put together with Rebecca. The QR code, if anybody wants to scan that, this is going to come out in the next few weeks, and it really will go over all of these devices, both active and passive. Okay, sorry, my slides got a little order. This is some of the passive devices. So to introduce this, this is the advanced sling, and I think most of you are familiar with this, polypropylene mesh, transobturator sling, very similar to what you saw earlier in the female session. The Virtue is a forearm sling, polypropylene, really not that different. Okay, now we get over here to Argus and the Argus T. And this is an adjustable sling. You have a pad under the urethra, and then you have these silicone beads on the side that you can continue to pull to maintain tension. And then you have your atoms. So the atoms you can inject into this pipette and add fluid. So these two devices are sort of like AUS meets sling. You have polypropylene arms or maybe silicone arms, and with a silicone pad here that's going to be inflatable and adjustable. And then, of course, the ProACT device that you've been hearing about. ProACT comes in a couple different sizes, the female version in 8 and 9, and then the 12 and 14 on the male side. So let's talk a little bit about some other things with active devices and why we worry about it. I mentioned the cognitive issues, and I think that's something that we're all aware of. We know the device can work very well in certain situations, and a lot of this is about patient selection. When we have these talks, the number one slide is, how do you select your patients? And that's hard, and that's very personal to the surgeon and to the patient based on your experiences. The Conti system is not FDA approved. The ARTIST device it will be adjustable and hopefully limit the risk of urethral erosion because you can turn it off at night. So even with your AMS 800, if you can get the patient to turn it off at night, at least they're avoiding 8 hours of constant pressure on the urethra. You might say, who would that patient be? It'd have to be someone who was dry at night originally, right? Otherwise, they're going to want to have that benefit. And then the Victo would be an electronic that you can use and have some success with that. We also did a book chapter recently. Grant Vandervoort, who's going to be a fellow in Chicago next year, helped us put this together, and very similar to our review article, really went through all of these devices. So I encourage you to look at these important articles. So, but I'll just summarize here on the suburethral devices, just putting it as a group, right? Suburethral implants are growing. It's a dynamic field. There's excellent long-term success. These devices are not new. The data is maturing, and I think we're starting to see that. Suburethral devices are indicated for those not suitable candidates for the AUS. In other words, they can't operate it, they don't understand it, they don't want it. Suburethral implants can be used to treat patients mild, moderate, severe. So I think there's this idea like, oh, I'll do passive devices for mild and I'll do AUSs for severe and maybe flip a coin for moderate. But we struggle to really define what mild, moderate, severe is. We'll have different definitions. So there's a wide range of devices on the global market. In the US, we have 2 passive devices and 1 active device. ProACT and Atoms are the only devices that you can titrate to the desired effect. So you can bring the patient back for postoperative adjustments. So here's where I'm at now, 2024. You heard a lot about this today, non-operative management. As a urologist, you should be able to advise your patient on which penile clamp to use, which condom catheter to use. I'm not going to go on that, but I can spend an hour talking about non-operative management. This is important. The sling is a therapy I still use, but I'm using it less and less. It's hard to find the ideal patient for this, low volume, no radiation, especially if you're in a very tertiary practice. The artificial urinary sphincter still plays a big role, but now mostly ProACT for me. Since I started doing ProACT, my artificial urinary sphincter volume barely dropped. So it's not really, ProACT's not really replacing that. It's just taking you to areas maybe where you wouldn't be looking. Mild and very severe in people after erosion. So it's the 2 ends of the spectrum. I saw a debate at the GERS this year, and I think Dr. Westney will talk about the devastated outlet and when to divert. So I'll defer to her on that point. So here's the device. It's just a silicone balloon. It's put in with the metal trocar. You got these subcutaneous ports. You can do adjustments. The techniques, you heard from the speakers earlier today, there's a lot of techniques, the Foley catheter technique, the fluoro technique, the flexible cysto, the truss, the rigid. And I tell people, if you do flexible cysto in your practice, that's what you prefer, use a flexible cystoscope. If you like rigid, use rigid. If you're good at ultrasound, you have experience doing prostatectomy and doing trusses and brachy, and you're an expert with ultrasound, maybe aquablation users, they all like the truss. This is a slide from Matt, and you heard from him earlier. We did a talk similar to this together, Southern California, a few months ago, and when we went out to City of Hope, and he talks about getting the trocar and the scope lined up and having that feeling of where the two will bang together slightly, and then the medial flattening on the balloon. This is from Antonio Beltran, now in Nebraska, similar to Matt, and if you're going to watch any of these webinars, does a great job explaining his technique. Andreas Grigori is a urologic oncologist in Milan, Italy. I had the fortune of watching him do procedures. I watched him do 4 of these under ultrasound in the morning at the county hospital, and then he went to his private practice in the afternoon. These were all patients he treated. These were his prostatectomies. And how people treat incontinence in Europe is very different in the United States, and it's often the same provider. So he's an expert at ultrasound. He's an expert at prostatectomy. He's an expert at ProACT. So in the U.S., and what do? I use flexible cysto technique primarily, combined with fluoro. I will do truss if there's a prostate in situ. I think there's some value there. So let me go through some of the key steps. This is the key slide. If anybody wants to take a picture, I'll share this. I have a QR code at the end of the talk. But these are the 8 steps, and I'm going to go through these quickly, but you really have to be very diligent on how you set the room up. You have to have a good team in the OR that you're going to work with, right? The right x-ray tech. All of this needs to come in place to have a successful procedure. Okay, so here's the setup. This is an implant, okay? Don't think of it any other way. Don't show up and accept just cysto draping, right? Drape it out like an implant. Have your Urecept solution there. Have a separate table for the implant. Really go into this with that mindset. Here's how the room's set up. Nate Connington helped me with this animation and was involved in kind of us developing this technique. And you want to have your screens facing forward, right? Just like you do on a ureteroscopy. You can see the cysto screen and the fluoro screen stacked together. This is the perfect setup. It can be right or left, but you certainly don't want the screens on the back of the room where you'd have to turn around and start tunneling. And by turning your head, that's when you're going to get off line. I talked to the residents and fellows about cord management. You got to get your SED cord out of the way, your Bovie cord out of the way. If you use one, I don't even use a Bovie pad now, and really elevate the patient so when you're x-raying laterally, you're not hitting this. This is our scrotal sling. We get the scrotum out of the way, and we all have our tricks for doing that, and I just use some Ioban. And then we use the C-armor drape. The C-armor drape, similar to what you use for interstem. These are some pictures from my practice, the non-radiated versus the radiated. So everybody gets a cysto pre-op. I don't think we're doing cystos enough. You heard that this morning compared to other specialties. For those who weren't there, you walk in to see a GI person, you're going to get a scope 80% of the time. You see an ENT person, 50%. You see a urologist, less than 20%. So we're probably not doing enough cystos to really understand this anatomy and help us target. So this I can compress. This I can compress. But if the whole bladder neck was wide open and looked like this area, I can't compress that with balloons. So I think a rug and a cysto is a nice way of assessing. Okay, so let's look at some of these pictures here, and hopefully these videos will play. Yes. So here's our non-radiated. And I use the Veris needle. I tell people this is the practice swing before you throw the real trocar. Not as sharp, the needle retracts in, just like you're popping through fascia, you pop through the urogenital diaphragm. Only one side of the bladder is moving, so I know I'm through the diaphragm. And then on this radiated case, very little movement. So I know I'm in the right spot, I gotta be. I can see his clips from his radical prostatectomy, but I'm not getting as much movement. So that's just kind of getting a feel, okay? This is all done with tunneling, so you're trying to lock in and get a feel of how you're gonna do this. And then you're going to go for your sharp trocar, okay? So once you're in there, the sharp trocar is going to come in and then get replaced for the blunt. This is that radiated patient I showed you in the previous slide. Still not a lot of movement, but I know I'm there. Okay, and this is just the tapping motion. I tell people when you throw the trocar, right, this is not an undercut, you're just jabbing. Okay, you don't want to lean into it. You don't want to use your chest or your shoulder. Very gently advancing that trocar, tapping, rocking, not pushing. And this is what it would look like cystoscopically. Focal movement. Cystoscope retroflex. I'm at the 3 and 9 o'clock position. I'm feeling pretty good about this right now. Okay, and then we go ahead and lube up the channel and then deliver the balloon. I won't show you too much on that. You got one balloon here to inflate it, and the other one, you can see this balloon is not a nice circle because there's a lot of radiation and scar tissue there. This is how it should end. You should be about 1/2 to 1 centimeter from the bladder neck and about 0.5 centimeters from the urethra. You want to be careful to not get too close to the urethra. And then this is really a key picture here on the lateral view. I really want to see one balloon. Even though I have 2 balloons in, I know now they're perfectly aligned. I can see the radiopaque markers. And when we're finishing up the case, I want these overlying the urethra, and I want them stacked on each other. You go ahead and tunnel your pipettes into the scrotum from bottom to top, not hard there. And then this is just summarizing everything. This is our setup. This is our tunneling, how it looks cystoscopically, and then balloon deployment. The ultrasound technique, I wish I was better at this. I'm trying. David Hadley's been working with me on this, and we have some creative ideas. The manufacturer does not endorse this technique right now. If you read the IFU, and Seth showed a few of those earlier today, it's important to read how the company recommends you do the procedure, and you want to stay on script as much as you can. Okay, what about the adjustments? We can do the adjustments in the office. This is a picture of one that was done in the OR just for privacy, but it's very easy to pass the needle through the skin and do your adjustment. It's a tissue expander. I usually do 1/2 to 1 milliliter. So lessons learned in the next few minutes. This is how I've been with a couple of new procedures. Boom, you're off to a great start. You're loving it. You know, Matt mentioned this 14-minute procedure, and then all of a sudden the wheels come off the bus and you don't know what just happened. And then you start figuring it out because now you're realizing why you're getting a good result. Initially, you thought you knew everything, and then you had to go back, and I like to say, watch the game film. Baha showed that earlier in his talk. Going back and looking at your cases, recording your data, have that spreadsheet in your practice so you know how it's performing. So here's a lesson that I learned. This is case 67, so I'm pretty well into my experience, and I know I need a lateral film because these balloons, I don't know, are they above the diaphragm? Are they not? I'm sitting here debating, should I take these out, move them higher? How's this going to end? I do a lateral film, I'm not even close. Okay, here's my cystoscope. I placed them way posterior. This is a case that would have failed for sure. What do? I just go ahead and retunnel. Take the balloons out, tunnel deep. You can see where I am now. Flip over to lateral view. Got the 2 balloons stacked on each other. Okay, so you're going to learn as you go through, and there's enough experience that hopefully you can learn from others that you don't have to make these mistakes. You can be too lateral. You can be too caudal. Or you can be too posterior. You could even be too cephalad. So you want to get it in the right spot. Mark that image at the beginning of the case. See where everything's funneling. 1/2 centimeter from the bladder neck, 1/2 centimeter from the urethra. This is a case here that I showed you earlier. I'm tapping this out. Everything's great. Here's my lateral. Tap, tap, tap. I'm getting good urethral movement, bladder movement. I'm pleased with that. Here's flipping over to the lateral view, and I compare this procedure without a lateral to doing an interstim without a lateral. I personally feel you need the lateral view. Others feel differently, that they can trust more with the tapping. But here on this lateral view, here's my scope in the urethra. Here's my inserter. There's no way I'm too posterior. I got one in. That's the hard side because it's the first side. The second side is going to be easy. You're just going to track right along that trocar in the lateral view to get into place. Just a couple fun things, some terms that we invented. Hopefully you guys will repeat it. The drooping lily, the snowman, and the trampoline. The drooping lily means you hit the diaphragm and that balloon just bends, okay, like a flower wilting because you're hitting this tough diaphragm. You're not deep enough. The snowman is this waistband you'll get when you're within the urogenital diaphragm. So this snowman turned out to work. I got lucky. This snowman migrated downward, and I had to revise that side. This is what happens. Go back and look at the film when you have a case that failed and try to learn what went wrong. Okay, and this is the last slide I'll show. This is the trampoline test. Just having a little fun here, pulling on the balloons. And if you really study this quickly, watch this bladder neck. I pull down, here comes the contrast. Right there, person's leaking, balloons pop back up, now I have continence. And so this is a patient that could be continent right off the table. Thank you very much.